So today I'm going to talk about opioid withdrawal in our neonates and pediatric patients. If you think back to previously times I've talked about general reasons why neonates and pediatric patients in the NICU and PICU may be on opioid pain medications, and also talked about last time with drug screening and kind of in utero exposure to certain substances that our neonates may then end up withdrawing from. So today I'm going to go into more detail regarding that. So I'm going to describe the epidemiology, etiology, risk factors, clinical presentation, monitoring tools, and overall management of opioid withdrawal in our pediatric patients, but then really compare and contrast the differences between NAS, or neonatal abstinence syndrome, and IOAS, or iatrogenic opioid abstinence syndrome. To get us started, I want you guys to watch a video to get you thinking about what withdrawal might even look like. So there's a link in your slides, and after you watch the video, I want you to reflect on the following questions. So what did you see in the video? What could be causing these symptoms? And then what are other possibilities on your differential? So once you do that, then I will go through some more additional information. So first, it's important to kind of compare and contrast the etiology with NAS and IOAS. So when we specifically talk about NAS, it is really the in utero exposure to narcotics. So it's our babies when they're born, if they were exposed to opioids in utero. And so one of the things that's really important to think about when the baby is born is what was mom's history? What drugs was she on? What doses, if that information is available? And how long was she on it? Was it just a couple of weeks during pregnancy, or was it the whole pregnancy or an extended period of time? So as much of that history that can be obtained is helpful because if you think about it, the more drugs, the higher the dose, the longer the mom was on it, really the more exposure the baby had to it, which in turn could increase the baby's chance of withdrawing from those medications. And then when you look at IOAS specifically, so I talked previously about how our patients in the NICU and PICU sometimes may require continuous infusions of opioids, and this is part of the kind of the mainstay of the analgesia and sedation regimen. And so just like the mom's history with NAS, looking at the history of exposure with IOAS is important too. So looking at the specific drugs, cumulative dose, and duration of exposure as well. And then oftentimes if a patient is in the NICU or PICU for a really long time, they maybe have been on several courses of these narcotics as well. So that is important to take into account too. When we think about this overall exposure, what the concern often can be is if we stop the medication abruptly or taper it too quickly, this can lead to withdrawal. So if you think about it for NAS specifically, if the baby had been exposed to these medications in utero and all of a sudden the baby is born and no longer is being exposed to those medications, that could lead to withdrawal. And really the same thing for IOAS. So if we're giving a patient a continuous infusion of, say, fentanyl, and we stop that medication abruptly, that could lead to withdrawal as well. So it's important whenever we're on those medications, or if maybe a baby was exposed to those medications in the utero, you take that into account. One of the other things that's important to think about is the half-life of the drugs in relation to monitoring and really starting treatment. And kind of what I mean by this is, say we had a patient that was exposed to narcotics in utero. It may stay in their system for a little while, so we may not expect them to show signs of withdrawal immediately, but it could be a couple days or days later that you might see it. Same thing with IOAS, certain medications, it may not be immediately, it could be days after. So it's always important to think about how long the medication may stay in the patient's system. And kind of on the flip side, if you're starting a medication, you might not see it start or to work immediately. It may take some time. So often the approach, especially with the IOAS, is when they're on a continuous infusion, of a medication, to help us get off that medication, what we can do is slowly wean that drip, but add on an enteral medication at the same time. And then that can help us facilitate weaning the drip. Once we're off the drip, we can taper off the medication. Same kind of thing for NAS. If they're, say the baby starts showing us signs of withdrawal, so we'll put them on a scheduled medication, and then once their withdrawal is better and they're not exhibiting as many signs and symptoms, we may slowly taper them off that medication. So you never want to abruptly stop the medications. So when we think about the epidemiology of withdrawal, how common is it? So in specifically looking at iatrogenic withdrawal, the exact number of cases is unknown, but it had previously been reported that approximately 94% of PICUs identified it as an issue. So it is definitely something that does come up. Specifically looking at our NAS, or neonatal abstinence syndrome, in the United States in 2016, NAS was reported to occur in about 2 out of every 1,000 births in hospitals. And looking at the adjusted hospital costs specifically for NAS, it's approximately $573 million. So it is definitely something that can be quite costly. Specifically looking in Mississippi in 2017, NAS occurred in 2.4 out of every 1,000 births in the hospital. So it definitely is something that does occur in Mississippi. When looking at the pathophysiology specifically of withdrawal, I think it's always important to first think about how the medication itself works, and then what could happen if you stop that medication abruptly in withdrawal. So looking specifically at the patho, it works in a couple different mechanisms where you would see withdrawal. So you can see activation of the excitatory amino acid receptor, NMDA. You can also see superactivation of adenylate cyclase, and then also G protein coupling. When we think about what puts our patients at risk for NAS or IOAS, there are a couple different things. So NAS specifically, being male is thought to be a risk factor, and then also maternal buprenorphine use is actually associated with more severe cases of NAS. And then when specifically looking at IOAS, some of the risk factors are mechanical ventilation, neuromuscular blockers, and then ECMO. The way I think about this is a lot of times patients, when they're receiving mechanical ventilation, when they're on neuromuscular blockers or ECMO, they require a sedation and analgesia regimen, which often includes an opioid, like I mentioned earlier, so that puts them at risk for withdrawal. And I know I briefly mentioned this earlier, why it's so important to look at the overall history and exposure of the medication, because your higher opioid doses and longer exposure can increase risk of withdrawal. And there was actually a study looking at this. The overall fentanyl exposure was the drug specifically focused on, and then the incidence of withdrawal. And the primary objective was to evaluate the occurrence of IOAS specifically, so our iatrogenic type, in pediatric patients receiving a fentanyl continuous infusion. And it was a prospective case series, specifically looking at PICU patients in the pediatric intensive care unit, less than 2 years of age, on a fentanyl continuous infusion for at least 24 hours. So they had to have been on it for at least a day to be included in the study. And essentially looking at the results, two main things they were looking at was, is there a certain dose associated with withdrawal, and is there a certain duration of the fentanyl exposure that's associated with withdrawal. And what they found is a cutoff point of 2.5 milligrams per kilogram cumulative dose of fentanyl. If the dose was less than that, some of the patients demonstrated withdrawal, where some did not. However, for all the patients that had greater than or equal to 2.5 mg per kilo cumulative dose, they all demonstrated withdrawal symptoms. And looking at duration, 9 days of the fentanyl continuous infusion was deemed the cutoff. And if you look at less than 9 days, some patients demonstrated withdrawal, some did not. Versus when you look at the cutoff, anyone that was on it for at least 9 days, all of the patients experienced withdrawal from it. So the takeaway point here is the higher the dose, the longer duration of exposure, the higher probability the patient will withdraw. So thinking back to the video at the beginning of this and some of the symptoms you saw, when we think of withdrawal, we really can classify them into 3 main systems: gastrointestinal, central nervous system, and autonomic nervous system. So looking at GI, some of the symptoms you can see are feeding intolerance, diarrhea, and vomiting. And if you think about one of the main side effects of opioids in general is constipation, so it makes sense that the opposite would happen when you're withdrawing from the medication. So it'd be diarrhea in this case and not constipation. When you're looking at the central nervous system, some of the symptoms you can see are sleeping disturbances, agitation, and tremors. And then specifically in the autonomic nervous system, you can see diaphoresis or sweating, hypertension, so elevated blood pressure, tachycardia, so elevated heart rate. So these are some of the symptoms you can definitely see with withdrawal. So how do we treat it? So if you think about it, if our patient is withdrawing from an opioid, it makes sense to add on an opioid. So thinking back to how they work, it's important to think of if they are mu agonists, if they're partial or full agonists, but then also, are they short acting or they're longer acting? So I'll say most commonly the opioids that we will use for drug withdrawal are morphine and methadone. And so in our NICU, routinely what we use for NAS, so specifically if the baby was exposed to narcotics in utero, we will give morphine, which is a shorter acting medication, but we will schedule it and give it to them every 3 to 4 hours, essentially around the clock until they are stable. And then we will start slowly weaning the morphine as tolerated. Another agent that we can use is methadone. And this is often what I think of to use for specifically IOAS, or iatrogenic opioid abstinence syndrome. And this is a much longer acting opioid. And what we'll often do for this is they're still on that continuous infusion of, say, fentanyl. We're ready to start tapering that. We don't think the patient needs as high doses anymore. But to help us facilitate that weaning so they don't demonstrate symptoms of withdrawal, we can add on, say, methadone, which is longer acting. We add that on board, typically for a few days. And then once we've stopped the drip, once they're stable, then we will start weaning that methadone off. But it can be helpful to get them off the continuous infusion, and then we can wean the other agent. There are some other medications that you could use for adjunct, so it wouldn't be monotherapy, but if a patient is still demonstrating symptoms of withdrawal and you can't get their symptoms to improve just on the opioid, you can add on an adjunct agent such as clonidine or phenobarbital, and they essentially are acting on a different mechanism than the opioids themselves. So I know I talked some about the management already, but there's no definitive guidelines for the management of withdrawal in our patients. But the general approaches, like I mentioned, are gradually tapering the continuous infusion if they're on one, and then adding on an enteral agent, and then tapering that agent as tolerated. But one of the most important things is monitoring this to make sure, one, is our patient exhibiting withdrawal? If they are they improving when they're on the medication? So now we're going to talk about how we monitor. So first I want you to watch another video, and I have some questions once you've watched it. So what are some of the criteria included in the scoring tool discussed? What are some of the challenges associated with the scoring tool? What was the purpose of the quality improvement project discussed in the video? And then what were some of the benefits seen from the quality improvement project? So I want you to get you thinking about how we monitor and that kind of thing. And then I'm going to go into some more information after you've watched the video. So there are different monitoring scoring tools that we can use to monitor for withdrawal. I'll say the most common ones are the modified Finnegan and the WAT1, or the withdrawal assessment tool 1. So those are the ones I'm going to go into more information about. When we look specifically at the modified Finnegan scoring system, this is the one that is most commonly used in NICUs. So this is what we use here. And it was first developed for assessment of drug withdrawal, specifically in neonates who were exposed to narcotics in utero. And the tool consists of 21 different criteria that the nurse will assess. It's typically the nurse that's going to fill out basically this scoring tool and input the results into the patient's EMR. And so once the score has been essentially tallied up, a score greater than or equal to 8 is indicative of drug withdrawal. So I have a link listed that if you want to go click on it, you can basically see the different criteria that are included, but then also there's some additional helpful information. And then the other one is the Withdrawal Assessment Tool 1, or the WAT1. And this was specifically validated in pediatric patients greater than or equal to 14 days of age. And the tool actually, it consists of symptom monitoring, different criteria, but then there's also a stimulus test that the nurse has to do. And then some of the scores are based off of the results of the stimulus test. And for this one, a score greater than or equal to 3 is indicative of drug withdrawal. So you can see the score cutoff varies depending on the tool. And there's a link if you want to look at that calculator as well for some additional information. I will say whenever you use any kind of scoring tool, it's good to look at the results, but then it's also important to consider, are there other factors or any limitations potentially with the tool when interpreting the scores. So now I'm going to go into a little more information regarding that. So when I was a pharmacy resident, I actually conducted a study to look at this, because one of the issues we were finding is that some of our NICU babies would go to the PICU for heart surgery, and after heart surgery in the PICU, they were monitoring withdrawal using the WAT1 scoring tool, and they may not have been necessarily showing signs of withdrawal, but then when they came back to the NICU, we would use the Finnegan scoring tool, and we were finding there were signs of withdrawal. And so it kind of created the question, with the different scoring tools, is there one tool that may be better to use than another, or are there just certain criteria it's important to think about? And so the primary objective of this study was to compare the average withdrawal scores determined using an adjusted scoring system and the modified Finnegan scoring system. So when we created this adjusting scoring system, it excluded non-neonatal criteria, because if you remember, I said the WAT1 we can actually use in patients greater than or equal to 14 days of life. Technically, those patients may still be a neonate as long as they're less than 28 days of life. So there's some overlap potentially in the tools that we can use. And so this was a retrospective observational study. And so the study population was the patient needed to at least be 2 weeks of age, so we could use essentially that WAT1 scoring system, with a corrected gestational age of at least 37 weeks, who had cardiothoracic surgery and was transferred between the PICU and the NICU, and received a continuous infusion of opioids for at least 5 days and had a cumulative dose of at least 1.5 milligrams per kilogram. And this is a picture just showing you the modified Finnegan scoring system criteria. So like I mentioned, there are a lot of different criteria included in this tool. But then on the right is the adjusted scoring criteria. And essentially what we did is we took out these non-neonatal criteria and created our own scoring system. So this is not validated. This is more a pilot study just to explore the topic a little bit. And so once we did that, we had 22 patients were included in the study. And so we looked at the WAT1 scores that had been collected in the PICU before they were transferred to the NICU. And so the median WAT1 score in the PICU prior to transfer was a 1 with a range of 0 to 3. And overall, 7 patients included in our analysis had WAT1 scores and modified Finnegan scores indicating withdrawal. But what we did is we had created an AUC essentially comparing those adjusted scores and an AUC for the modified Finnegan scores, and we found our adjusted scores were statistically significantly lower compared to the modified Finnegan score. So this just suggests there could be an overestimation of withdrawal when using the modified Finnegan in some situations. So it's always important to think about different criteria, and if that criteria that a patient may be scored elevated on, is it withdrawal or is it something else going on? And an example is if a patient has an underlying seizure disorder and they get scored for seizures, is it because they're withdrawing or is it because they have seizures at baseline? So kind of the point of this is just whenever you have a scoring tool, it's always important to assess it, because even though it's a great tool, there may be some criteria you need to kind of analyze and think through a little bit more. I have some links to some additional resources if you want to explore more about NAS. I think these are some helpful sources to go to. And so in summary, NAS is caused by in utero exposure to narcotics versus exposure to continuous infusions of opioids can lead to IOAS, or iatrogenic opioid abstinence syndrome. And those higher doses and longer duration of exposure can increase risk of withdrawal in our patients. And so abrupt discontinuation or rapid tapering of agents is associated with withdrawal. And there are many symptoms associated, but mainly in your GI, CNS, and ANS symptoms. And so the two commonly scoring tools used are the modified Finnegan in the NICU and the WAT1 in the PICU. And it is important to consider many factors when assessing and developing a plan for a patient at risk for drug withdrawal. And like I mentioned, there are no definitive guidelines for the management of withdrawal. Now I'm going to switch gears and give you some cases to review. I'm not going to specifically go through them during this recording. I want to give you time to review them, but there'll be another slide deck where I'll do a recording with, and you can review the answers in those. I will say, if you look, the first case is a neonate, so the patient is in the NICU, and you'll see some of the symptoms listed for you to review. And then you'll see some questions to answer, and you'll see there is a link for the calculator to help you using one of the scoring tools to score the patient and see if the patient is experiencing withdrawal. And so you can answer those questions for the first case. And then you'll see there's a second case as well. This patient's a little bit older, so now is 3 years old is the patient, and this patient is in the PICU, and so you'll see some of his general history information, a few questions on this slide, and then on the next slide you'll see some of his symptoms and some more questions and another link to a calculator to help guide you. And like I mentioned in the other slide deck, I'll review the specific answers to the cases, but want to give you time to work on them first. And so that concludes this presentation. So thank you very much for listening.